And thank you very much, everyone, for taking a little bit of time today to spend with us as we chat about all things AI in our health and social care system. So welcome to Digital Dispatches. As I say, today we are focusing on artificial intelligence in health, and hopefully not as hype and not as some distant future concept, but something very real, something that's already here and shaping beginning to shape how we work across health and social care. So I'm Tom Simpson. I'm the director of DHCNI, and I'm the deputy CDIO for the Department of Health. So turning to AI, it has and it continues to move really remarkably quickly, and move from something theoretical to something practical, from something quite niche to something ever more ubiquitous. And across health and social care, it's here. Yeah, we're already seeing it help in a number of ways. Clinicians interpreting scans, AI to support workflows, AI assisting administrative teams with things like correspondence and even summarizing meetings and moving towards sort of clinical notes as well. And more recently, we're actually starting to see it touch frontline consultations and everyday operational tasks. So what I'm getting at, these technologies are here. Their use is becoming more and more common, and we should absolutely expect that trend to continue. So the question in HSC now, it's no longer should we use AI. The real question actually is now, how are we going to use it? How are we going to use it safely? How are we going to use it ethically? How are we going to use it effectively? So hopefully that's a little bit of what today will be about. Not hype, not abstract theory, but a practical, grounded conversation on what AI can actually mean in clinical and organizational settings. And I'm really pleased that with today, we're going to spend a particular focus on primary care. We've recently, very recently, this week, published the HSC AI framework. So we'll talk a little bit about that. That's been developed as a collaborative process with some oversight and direction from the HSC AI steering group, input from a number of different key stakeholder groups, including things like our enterprise architecture board, our data coordination board, engagement with trade union colleagues and so on. So we'll talk about that in a bit of depth in a bit, but I'm not going to spend the whole session running through that. And what I will say is, and to be very clear from the outset, this document is not a policy. It's not a strategy. It's certainly not the final word. It's actually a starting point, a practical starting point, a bit of a shared reference that can help us as a system to think about how we navigate the opportunities and challenges of AI together and consistently. I feel that it fills a gap that wasn't there. And already we might question where we need to go further in not just presenting questions to ask and considerations to be made, but in practical terms, what more do we need to do in terms of supporting and driving consistent, meaningful and effective deployment of tools across the region. So whilst the framework itself is a good first step, there is definitely more opportunity and more potential to be realized. We absolutely recognize that. What has been published this week, though, is high level and deliberately non-prescriptive. Every organization in the HSC is likely to be at a different stage with this stuff, and that's fine. That's okay. That's to be expected. And what the framework aims to do is set out a sense of what good looks like or could look like, principles around things like safety and transparency and fairness and human oversight and data protection and value, and whilst also supporting local autonomy, local policies, local decision making. You know, that's something that hopefully comes across clearly within the framework. It draws on some best practice from many different sources, but areas like NHS England, UK government, the Information Commissioner's Office, MHRA, World Health Organization, and others. But it's very much so grounded in the realities of our system here in Northern Ireland. And its purpose is simple, I think: support innovation without stifling it, offer clarity rather than complexity, and probably most important, give us something that helps us move forward with a bit of confidence, even when the path isn't always clear. Give us something that helps create that bit of momentum that we can build on. But luckily for all of you folks that have taken the time to either join us live today or watching this back, today's session is definitely not about taking you line by line through that document. And instead, during the next sort of 50 minutes or so, we'll explore a few different things. First, what AI actually means, especially in everyday clinical practice, what feels helpful, what feels promising, what maybe feels a bit challenging. Secondly, how we're seeing AI showing up right now in real settings, and not just in large hospitals or specialist domains, but increasingly the opportunities around primary care, which, as we know, is such a crucial part of the system, such a large part of the system. And then thirdly, I'll go into a little bit of depth on why having a shared framework, a set of guiding principles, can help us in making sense of this space and make better decisions and build public and professional trust as we go. So with that all said, that leads me on to our guests. I am so pleased to be joined today by Dr. Sterling. So Patty is an incredibly thoughtful, curious clinician who's been exploring AI in practical and meaningful ways. And he's supported the development of our framework through his representation in the HSC AI steering group. And he brings a depth of experience from primary care. So an area where we know demand is high, time is tight, and the potential for AI to support safe, effective practice is likely to be huge. But it's also an area where technical governance considerations mean realizing that potential certainly isn't without its challenges. Primary care voices are absolutely essential in shaping how we think about this as a system. So I'm especially pleased that Dr. Sterling is participating in today's digital dispatches. I'm also joined by some colleagues from our own DHCNI team, so thanks to Dawn and Jen who kicked us off, but also to Eddie Ritson, who will help ground the discussion in what AI actually is, how these tools can work, where they add value, where we maybe need to tread carefully. So today is really about lived experience. It's about clinical judgment. It's about real world reflection. It's about asking honest questions and sharing where we're learning. I don't think we need all of the answers to get started. We do need to move with purpose, curiosity, and with care. And that's the spirit of the framework, and that's hopefully what the spirit of today's session will be. So thank you very much for joining us. And with that, let's get started and into a little bit of the detail. So before we dive into the clinical perspective that Dr. Sterling is going to take us through, I think it would be useful to take a bit of a step back and start by grounding what we actually mean when we say AI in a health and care context. So in the framework, we describe AI as potentially being considered as just another digital tool, right? It's part of the broader transformation of how we deliver care. But we need to recognize that It's a bit more than that, yeah. It's a digital tool that brings its own considerations, particularly around safety and transparency and data governance and human oversight. So it's familiar in some ways, but I think it also asks us to pay particular attention to things like explainability, fairness, how we build trust in the outputs that it can generate. Perhaps a simple way to think about AI is maybe through sort of three broad families of AI tools that we're already seeing across the HSC. So tools that recognize patterns, things like imaging support, early risk prediction, triage prompts, that sort of thing. So that would be one. Another would be tools that work with language, things that summarize documents, drafting letters, helping with correspondence or clinical notes, assisting in decision-making conversations, those kind of things, and things that you're probably quite familiar with outside of work as well, if you make use of any of the kind of the large language models. And then thirdly, tools that support workflows, so things that automate repetitive admin tasks or can improve search and retrieval or helping teams manage information more efficiently. And primary care is a space where all three of those can intersect in terms of consultations, record keeping, communication with patients, and flow of work. I'm going to just wait a moment till we mute that, because someone shouting no, no, no at me as I'm mid-flow is a little distracting. I think that's really covered where I wanted to get to. But before we bring in Paddy, as I say, it's a little bit, it's probably helpful to understand a little bit more about what sits under the hood of this stuff, what's realistic, where these tools are already starting to make a difference. So, Eddie, do you want to take us through how we maybe think about AI from a technical and operational perspective, what we're seeing across the HSC so far, that sort of thing? If I hand over to you now, thank you.
Perfect. Okay. Thanks, Tom. I assumed the no, no, no was someone perhaps reprimanding a dog or a child.
Yeah, sorry, that was me. It was my cat was scratching the sofa. Sorry.
Perfect. I hope the sofa survived. Dawn, do you want to just click on to the next slide there, please? Thank you. Yeah, so my input here today is really just to set out as briefly as I can some of the broad context around AI and its relevance to healthcare, as Tom's already begun to do a little bit. And I'm fully recognising that there's quite a number of people on this call today, and a large number of those people on this digital dispatches know a good deal more about AI than I ever will. So I'm treading somewhat with some humbleness. So yeah, I think the question we find ourselves asking ourselves is whether AI is just another digital tool, or does it bring something fundamentally different that needs some specific attention? And the answer is probably yes to both the elements of that question. So at one level, it is just another digital tool. It may very well sit alongside electronic health records and e-prescribing and decision support systems and so on, digital triage tools. It may well run on the same infrastructure and may sit, invisibly in the background. But the thing is that unlike those traditional digital tools, it doesn't just store or transmit information. It does a good deal more than that. It has the potential to interpret, to predict, and to generate insights. So that shift from what we might regard as passive systems to active ones is what makes AI different, and really why it needs a focused attention from a clinical, ethical, and operational perspective. Click on there, Dawn, please, the next slide. Thank you. So Tom suggested maybe three practical types of AI that we are beginning to see. So pattern recognition. So this is probably the form of AI that most closely resembles what we might interpret machine intelligence to be about. So it creates the ability to spot patterns across large data sets, working often on probability. So examples might include, flagging suspicious findings on X-rays, like we're seeing in bone view and in digital dermatology, for example. It might be to do with risk prediction. So, for example, thinking about likelihood of hospital admission, deterioration, or readmission. We know already that Northern Ireland Ambulance Service are developing an AI application in this very area to predict demand on emergency 999 assets. Or another example might be in the area of population health, identifying patients at high risk of frailty, diabetes, or cardiovascular events. So the tools in this area don't and shouldn't be regarded as giving certainty. It's more about giving likelihoods. And obviously, they're only going to be as good as the data that they're trained on. And, bias in the configuration of those tools and the data quality that I mentioned matter. And they matter not just from some technical system point of view, potentially they matter from a clinical and service delivery point of view. So a second, I suppose, sorry, on that point, the challenge there for us is not whether the tools are clever. It's more about how much trust we place in them and how we blend them along with clinical judgment. So then turning to language-based tools, and this is perhaps where many people are seeing or some encountering with AI already, very much works along with natural language, text and speech, potential to summarize drafts, to give explanations and to categorize language. So examples might be in consultation note summaries, letter drafting and discharge summaries. And, the delivery of health and care is obviously very, leans heavily on language and communication, whether we're listening, explaining, documenting, finding ways to communicate about risk and uncertainty. So like communication and language is vitally important here. So language-based AI doesn't and shouldn't replace clinical reasoning, but it should help to reduce administrative burden, for example, in consultations through ambient note generation and in record keeping. And the risks here is probably not about wrong diagnosis. It's that the applications themselves may become over-trusted, or that there is the potential for unclear accountability for text which is generated. And then the third area suggested here about workflow and automation, which some people may see as being, the least glamorous dimension of AI, but nevertheless potentially valuable. So it's about automating and orchestrating what might otherwise be repetitive processes across processes and systems. So probably not so much about intelligence as is about saving time. And the thing we need to watch out for here is that automation errors could scale really quickly. So governance and monitoring matter importantly. Click on, please, Dawn. Thank you. So where do we see AI? And I think it's come back to what Tom suggested in his introductory comments. In due course, everywhere. We can't just sit back. We have to be at the forefront here. It's likely, if not certain, I would say, that we're going to see elements of AI in all areas of management, administration, policy, and in direct service delivery. So some of the key considerations there about, which I've sort of hinted at a little bit in what I've said already, about oversight and accountability, transparency, are really sacrosanct. We need to pay attention to these matters, hence the framework which we're here to introduce to you today, and which will encourage you to go away and read at your leisure. And then just to pick up on that last bullet point on the slide, which is that, when we think about AI, it shouldn't just be about, moving work around the system. It's about how we harness it to improve all that we do. So that's all I was going to cover in that session, Tom. I'll hand back to you at that point. Thank you.
Thank you so much, Ellie. So yeah, really good, helpful way to frame a little bit about the tools that we're starting to encounter. And that brings us to what I would suggest is the most important part of today's conversation. And that's about thinking about what this actually looks and feels like in terms of real clinical practice. So one of the things that we emphasize in the framework is that AI is ultimately about people, right? And clinicians, patients, admin teams. And it's about improving care, improving experience, and reducing some of the friction in everyday work. It's not, it certainly shouldn't be a technology conversation on its own. It's a service and it's a patient care conversation that technology may or may not be a part of. And primary care is a particularly important space in that story. As I said earlier, it's where demand is high, time is limited. The direct interaction between clinician and patient is really at the heart of everything. It's also a place where we know that emerging AI tools, whether they're, as Eddie has talked through a moment ago there, whether they're supporting documentation or summarizing information or even assisting with triage or helping with workflow, you can see the potential and the opportunity there to have very real, very immediate effects. So I'm really pleased that we do have today with us someone who brings that sort of deep clinical experience, a really thoughtful perspective on where AI genuinely is useful, where opportunities lie, and also where we need to maybe tread carefully. And Dr. Sterling has been both exploring AI in practical grounded ways, so testing tools, thinking critically about what works, reflecting on how this technology fits into the realities of primary care. In considering different experiences and different angles, Dr. Sterling's going to bring a real honest conversation about what's emerging, what's promising, what responsible adoption could look like from a clinician's point of view. So Paddy, feel free to take this wherever you think is most useful, and it's over to you.
Yeah, and apologies, I'm in a Belfast Trust Wi-Fi, so shout at me if the connection goes, and I can knock off the camera if you do not need to see my face. I really feel like I'm standing on the shoulders of giants, seeing the number of people in the room and the background and the technical specialization that's in the room, and so I'm really going to speak as a clinician from my safe space, because I see patients, that's what I do. I'm a GP partner up in Carryduff, but I also dabble in trying to help share a clinical perspective into some of the digital technology and some of the digital transformation projects. So I hopefully have a reasonable understanding, and I'm really nervous that I'm hoping this is a useful thing for you guys to hear how clinicians approach and are thinking about things. I'm probably going to just share my screen again, and hopefully this will all work okay. So hopefully you can see my slides, and it says AI in primary care, and then we're happy to move on with things. Does that work okay, Tom?
Primary mute button. Yes, we've got that. Thank you.
Perfect. So effectively, the guys asked me a lot of really good questions, and I'm going to try and work through them and try and answer them as quickly as I can. I guess the first and most pertinent question was, what's actually useful and what's just hype? And I think actually Eddie's already set this up really well. AI is not new, and particularly, in GP land, we've been working with codified records for a number of years, probably 15 to 20 now, depending. And so we're used to using some of these more, what we would consider AI. I guess one of the things about AI is I'm a Windows 95 generation dial-up modem guy, and a lot of the things that we considered intelligent back in the day, we no longer. We just think it's norm. And so we are using some intelligence and computer-aided intelligence in what we do already in our clinical EHRs. And again, we will often have rule-based concepts in how we deliver care in primary care. A huge amount of our population health management is around how we codify our information about our patients, how we then search for that, and then we can run different concepts to make sure that we're creating the appropriate recalls, and two, particularly if someone's in front of us, we create the right kind of concepts and programs to make sure that we're prompting alerts and recalls. And you can see just thrown in these slides just so you have an idea of just what some of our kind of monitoring will look like. This is dummy patient. Thankfully, we don't actually let our patients get that unmonitored in carried off, just to reassure any of you that live in BT8. And I guess the other thing is, AI is not this magic thing. And I actually think this is why the framework is such a great document, because it doesn't try and fall into that trap. And it's a real honest, practical approach to things. I think, we've all thought Encompass was going to save the world, and now we're moving on to thinking artificial intelligence is going to save the world. And again, I think that's certainly a fear from us that again, we think that this is going to do all the work, and we need to consider it in the whole. And I think the other really important thing is that I want people to understand is, I guess, AI isn't intelligence in the sense. It is just artificial intelligence, the science of making machines do things that would require intelligence if they were done by a human. So again, it's a bit like your washing machine doesn't know why it washes the dishes. It's a machine that can do that. And I think we need to remember that artificial intelligence does not have the same semantic context that we would have. It does not know why it thinks like it thinks, but it is increasingly good at looking like it does. And again, I will not go over this because Eddie's already done this really well. We've got different types of intelligence, and actually we've got those basic clinical decision supports that we're already using, and those simple and flexible non-intelligent ones. One of the really exciting things that we're seeing coming into the market in terms of as a clinician is that ability to do diagnostics, those kind of predictive. You give them a really rich metadata set, like those radiology images, like those skin cancers, and you can get a really strong predictive correlation diagnostic tool, and it will learn beyond the realms of human knowledge. So these are really good tools. I appreciate I've broken them down slightly differently, but hopefully it's maybe different to see them in a different sense. And then we have these analytical models that really look at trying to find new patterns that humans don't. So that these are all really exciting spaces for us as clinicians to get into, because we are moving from a basic yes/no logic sequence to we're actually starting to try and generate predictions or analysis that we would not have otherwise been able to access. And again, interestingly, there are other decision-making AIs that look for optimal strategies. And again, this is really exciting for things like if you think about an automated control of someone's insulin with an insulin pump, and that ability to control and be dynamic to the responses of the sugar, and then driving into that response of the output of the insulin. Now, of course, these need to be really tightly regulated. And again, there's a risk if there's not the right safety parameters, that these can make bad decisions or work towards the wrong goal. The biggest thing that we've seen and it has been, Eddie and Tom have both reflected, it's been so rapid, is the move towards generative AI, where the AI can actually try and generate new things, a deep sense of learning, using the large scale text as a kind of corpus or body of learning. The really interesting thing about this is it's kind of, if you dig into it, it's vector based, and it's like a really fancy predictive text. And so while it can often be really good, it can often predict things wrong. And that's why you're aware of the non-deterministic hallucination aspect of it. And that's really important for us to be cognizant of as we deliver care. So I guess Tom is like, what's actually useful, what's behind the hype? Well, actually, there's a really good opportunity for us to reduce variation in care, enhance the prevention of disease, enhance the prediction of disease, as you've heard about the model types. And again, there's a real good opportunity now for us to get into personalization and participation. obviously, and I think you guys are probably can all see this in your own workflows of just the operational aspects of optimizing flow, getting it right the first time. And for us in clinical practice, we want the right person to deliver care, and we want the right patient and at the right time. And again, we've already heard about automation decision support. And apologies because we're covering some of the same ground, but hopefully again coming at it from a clinical perspective. And I always try and drop into my slides when I'm talking about coding and data to my partners that good coding saves lives. And we are now moving into a world, and then when you work in GP, good coding saves lives from your practice manager murdering you, because if you don't codify it, it's not counted as work and it didn't happen. And I think one of the big things we're moving into is data is going to be really key. And why is that important as a clinician? Well, because if I'm using a clinical tool and I'm basing it off the information I have that's codified or structured, then I am really not interacting with that real person. I'm interacting with a digital shadow. And I think one of the real things I would like to impart with you guys is things like getting your SNOMED CT up and running and getting Encompass coding in SNOMED and getting those sort of really rich data resources, getting meta transferred from Encompass to primary care in a kind of more data rich sense is going to be really important, because increasingly with the power of these tools, we will be looking at someone's digital shadow and trying to make a care judgment or care decision or risk stratification based on that. So anyone, all my team in the Data Institute, this is a really key and strategic group, and if you are working alongside them, support them in that rollout. And I guess where am I seeing the opportunities? And I guess what we're also seeing is AI come in to improve patient experience, improve population health, which is my goal. I look after 12,500 patients, and I want that to be the most healthy, well, and active population in Northern Ireland. That's my personal responsibility. And I guess we all want to be able to deliver different and reduce the cost to society. Selfishly, I kind of want AI to improve the clinician experience. So how do I improve my ability to do my job and interact? And again, we always want that to impact on health equality. And I guess so Tom and Eddie had asked me to look at the landscape, and I want to chat to you a wee bit about what's happening in the clinical landscape that's really useful. And again, we're seeing it in different spaces. The biggest one is on our right, and we're seeing these kind of what they call AVT, the ambient voice technology. And these are really cool things because they use that generative aspect to kind of listen and generate a note what in line with what a consultation would be. And it's actually, I'm just using OpenAI to do just an example of this. So you can someone could put an example in the chat, but I'm full screen, so I can't see it. But if we say, if given an example of an HRT, we can see how we can create agents that will do certain roles, and the ambient voice guys will listen to a consultation and they will try and generate a note based on that consultation. The risk is that they may hallucinate things that didn't happen. So you can see how quickly and how powerful some of these tools can be. And again, just with the right prompts, you can generate a lot of data. And one of the other things, so again, these ambient voice technologies, they will listen to the consultation, they will scribe it down, but they can also give some clinical advice and building that in. And that is where these are going. They're usually class 1 at the minute. And again, some of them will move into a class 2 medical device, and that's where they're delivering more of that kind of clinical decision support. One of the really interesting things about that is that while it reduces the clinical admin aspect of that, clinicians are having to check and make sure that the notes are right. And certainly, I think some of our Compass colleagues are seeing this. Sometimes the notes are too long or too big or not focused. It can be harder to find the data in that. There's a couple of other things that are really interesting. Skin analytics is one of the higher MHRA classes. So that's AI that looks at skin lesions and tries to predict if they are malignant or not. So a really good way of having a virtual dermatologist, inverted commas, looking through and picking at the ones that actually we really need to prioritize and manage risk. one of the interesting things is they're going into the virtual triage and virtual receptionist space. Again, I just wanted to give you a demo of this. So you can set up agents that will do this sort of thing, and you're increasingly seeing them. So give me a UTI example. So increasingly you can see how we can create agents that will answer the phone. They will ask a few questions about that. So again, this is a scenario where someone would phone up just about their urinary symptoms, and then the AI can ask them a few questions about that. It can ask them a few questions about that. It can then stratify that into the clinical triage system, and then it can actually send a message back to the patient. And so it kind of red, amber, green risks. And there are tools that people are building out like this at the minute. There's Emma is one of the virtual receptionists that's out. Again, Eddie's already touched on some of this. There's really good opportunities to improve admin workflow and recall, and use things like some of these are my notes. And particularly for whenever we're trying to develop policy or we're trying to use clinical guidelines, we can use retrieval augmented generation, where really we're using those kind of generative LLMs to go find specific bits of data and base the generation on data to make it more accurate. Model protocol is a really interesting opportunity, is where actually we see the models actually have a suite of tools, and depending on the context and the question that you ask them, they can go get tools to do particular things. It wouldn't be a chat from Paddy Sterling if I didn't mention GPIP, and I think there's a really massive opportunity in that we have a regional data warehouse, and if we think a lot of these predictive and analytical and our ability to manage population health comes from a rich data set. We have really worked hard and built a regional GP information platform that has all the codified primary care data from across the region. And again, what I see as a really massive opportunity is for us to lean in to utilize this tool to help with some of those things that we have identified that are our goals. And I guess certainly we have GPIP, but we also have two main providers, Optum being probably going to be the universal primary care provider, and Epic being obviously the universal secondary care provider. So we need to make sure that we are, both of these guys are developing their own in-house AI solutions. Again, data's going to be so important, but we got to realize that it's only a shadow of the person. And again, we really sometimes over-focus on this kind of predictive aspect. I know I can show you all these really complicated data and these dashboards, but we always got to make sure as clinicians that we're presenting information that has an action with it. You know, it's a bit like our screening programs, in that we want to make sure that anything we do, if we're creating or identifying a population, that there's tangible benefit or interaction. So making sure that we don't fall in the trap of data for data's sake. Realizing that I'm really slow, so sorry for this. But again, we can see that there's a lot of benefits to this. Is a look at the ambient voice technology, and again, we can see how it actually, the patients really don't mind it. Patients are really happy for this if it improves their experience of care. And we've seen that with every technological thing we've brought in primary care. And so again, it reduces some of the cognitive load on clinicians. It actually allows clinicians to make much better eye contact. Patients usually report that it's a better experience because the doctor was looking and listening to them. And again, part of this trust that we build with our patients is part of being transparent and clear when we're using it. I was looking at actually some of the data about the guys that are using it more actively, and a few thousand consults in the ambient voice technology. And in fairness, I think patients are very accepting. They've had very little to rare refusals for it. And it's interesting, when I was building out some of those triage tools and I was chatting to guys about that, actually I had some of my medical students say they actually they would be happier speaking to an AI, because if it was properly secured and the data was all kept secure, they were happier that they'd be chatting to an AI than they would be chatting to the receptionist that they might meet down the street or in the shops. And I think that's a really good challenge to us that have grown up with one set of technologies. We have a whole generation that's growing into this technology and actually very comfortable with a digital first approach. Tom and Eddie asked me what worries me the most, and I think it feels like there's a few sharks in the water and they can smell blood, or at least they can smell budgets. And I think one of the big risks is that you're going to, if, yes, you've got this data that will help you form an algorithm and a model. We still have to do the implementation. There still has to be an action that we can do from this. And again, we still need to be focused on outcomes. And I guess I'm always worried about solutions that are looking for a problem rather than us approaching things in a problem goal and outcome oriented. And actually, one of the really lovely things about the framework is it points you to that. It really drives you back to that strategic, coordinated, and integrated care. And again, so I think what stops useful AI from landing well, it's actually that kind of thing where it's not integrated, it's not strategic, and we haven't worked from the outcome into the action, into the implementation. And I think we can, if we go back to those models of AI, lots of them will work in different ways to achieve different things. So we need to be familiar with the technology, and we need to be familiar with the clinical question that we're trying to, or the clinical activity we're trying to drive. And I guess what worries me most, well, this feels like a bit of a printing press moment. It feels like something really big is happening, and actually a bit like the printing press, there's a democratization of lots of things. There's a democratization of knowledge in a way that we had with the internet, but actually in terms of people's ability to understand health information, all my patients are putting their results into ChatGPT and getting it to interpret it for it. So there's a real democratization of health literacy in that regard, and something that we've actually really struggled to deliver because of the resource that's involved in personalizing care in that way. And I guess we're going to be a lot more open to patients asking us really good questions about that information. So there is a real sense that this is a change, and I think that is something that we will all fear. And I guess it's the kind of thing of, am I now teaching these systems how to do things and be out of the job? And I'm hoping at some level Elon Musk doesn't get his human robots out, and there's still someone that needs to look at a patient, examine them, and occasionally use a knife to cut out a lump or bump or something like that. So I think these are the things that worry us as clinicians. But I think it's exciting in primary care, and I think one of the really exciting bits, sorry, again, I'm hammering through this so that I'm not taking up Tom and Eddie's time, but is that actually primary care is this lifetime data set. We are so strong and digitally native, and we're really agile. And I think if we think about these more informed patients and actually looking that they'll be getting more personal advice and coaching, we are really getting to that goal of more efficient population health management. We'll be able to do more sophisticated targeting and recall. We'll be able to do more active prevention and reduction of disease. And actually the goal is that reduces some of the cognitive load. I mean, automating some of those aspects in the previous 2 points will give us more time to care for the acute and complex. And I think, look, there's unpreventable disease, there's disease and frailty and things that we can't prevent, and we want more time to manage those things well. So I guess I was scared about the printing press, but I'm actually quite excited about the printing press. And I think actually, again, it comes back to those goals, and I think these are achievable. And again, Tom asked me what looks good responsible adoption look like from a clinician's perspective, and I think it's that kind of thing. And again, the framework is so good at this. It's safe and secure, the privacy and data governance being covered off. And as a GP, we are 300 and something DPOs, so we are really grateful for that, those frameworks, and whenever some of that due diligence and those recommendation frameworks come out, because it's not practical for us to assess these and avoid the sharks that are in the waters for us. I think certainly for our relationship with patients, it's transparency. And I think, as Eddie's mentioned, it's the human oversight, keeping the human in the loop, because while they can do intelligent things, these things are not intelligent. And again, going back to being strategic, coordinated, and integrated, and that's the big challenge for you guys and DHCNI for you to help us with that strategic coordination and integration. And I guess I'm hopefully naturally pivoting back to Tom and again, how does the framework help? And I think it's, when I looked at that as a clinician that wants to be at the safe adoption of new technologies that deliver well for patients and for aid our efficiency and delivery of care, it's a really really beautiful guide of how we can go through some of the digital requirements, and even the fact that maybe they're not mandated, some of the data security requirements, and actually some of the ways of thinking about it. So I'm hoping that this is actually, like Tom says, a really practical and pragmatic tool for clinicians and for people that are involved in transformation of care to pick up and actually have a really good framework about how they can approach some of these problems and integrate some of these new technologies into care. I think that is all I wanted to trouble you with, but I'm really open to questions. But I suspect I've burnt most of my time, and hopefully that was pitched okay for you guys. And really happy to chat to anyone offline. I'm currently trying to build my own AI stack in practice. So if anyone's really good at Python, you can drop me a line, because I need a bit of help with that.
Amazing. Thank you so much, Paddy. That was a fabulous session, and Dawn will keep me right, but I think we're going to do questions just at the end. I know she's keeping track of hands and questions going into the chat and so on. But look, some really, really valuable reflections there. Thank you so much for that. I think a few bits that absolutely stood out for me from what you talked about was that balance between opportunity with regulation, risk management, the sharks that are circling. Data, good coding saving lives, particularly from your practice manager, maybe coming after you. I thought that was helpful, and particularly the GPIP shout out. I think this is really key, and maybe something on reflection that we could spend even more time on. But so much of these AI technologies are underpinned by the availability and quality of data, and good to hear shout outs for GPIP, good to hear shout outs for the Data Institute, and you will hear more about this at a system level in terms of our year of data for 2026. And then the final bit kind of that really stood out to me was that sort of bit around the reasons behind doing this. It's about patient experience, it's about health equality, it's about population health, and the reflection that actually patients are in the main happy for this, provided there's a level of trust there. So thank you so much for that. I just want to end by talking about the framework a little bit. So one of the things that we've heard consistently from colleagues across all aspects of the HSC is that whilst people are excited by the potential of AI, they're also very conscious of risk. And at the same time, what we don't want to do is create an unnecessarily heavy bureaucratic process when it comes to AI. But there is perhaps a challenge around a lack of clarity at times of what's allowed, what's not allowed, what are the key considerations, what should we do. And many people have kind of talked to me and with colleagues about wanting something that sets out what good looks like, and something that helps them think through the right questions at the right time, and something that gives a little bit of confidence that they're not missing, a key risk or a key step. And I think that's exactly what the framework is designed to do. It's there to support innovation, not slow it down. It's certainly not to put obstacles in front of teams who are trying to solve real problems. In fact, the point is it should make progress easier, not harder. I'd describe it as scaffolding rather than a barrier. It's just enough structure so that whenever someone has an idea, or when a team wants to try out a tool, or when a vendor approaches us with something promising, we're not left wondering, where do we start? Who needs to be involved? What questions should we be asking? Those sort of things. So look, what I wanted to do was just pick out a few. I'm definitely not going to go through it line by line. You can see on the screen there the link where you can go and have a read at the document there yourselves in your at your own leisure. I'm not going to go through that. But Dawn, if you could skip on to the next slide for me. What I want to do is just pick out a few ways where I think it can help and give some examples of what that might look like in everyday practice. So the first one is around setting out ethical and governance principles in a practical way. So transparency, risk awareness, fairness, human oversight, and those not as abstract concepts, they really do matter in the real world. So let's take an example of an AI tool, one that flags patients who might be at risk of a higher risk of deterioration. So that sounds like, yeah, could be helpful. But as soon as you approach it, some big questions start to emerge. So how would a model decide that? Who would be accountable for any action taken? How would we explain any output to a member of staff or even to the patient? So I think one of the things the framework can do is having some shared principles means we're not reinventing our ethical thinking every time a new product appears. It can help build trust in this approach because it's anchored in things that as a system we should and do care really deeply about: safety, fairness, professional judgment. So framework providing a bit of guidance on that. Second, it should help us think through whether AI is actually the right tool for the problem they're trying to solve. You know, making sure we're not running into the risk of AI is the answer. What was the question again? Not everything needs AI. That's a really important message, and we need to make sure we understand the question before deciding that AI is the answer. In my experience, sometimes the biggest gains will come from simple process changes, workflow changes, improving access to basic data. But other times AI absolutely will make a meaningful difference. So, you know, some of the stuff that we've talked about today. And what the framework will hopefully do is help us sort of pause long enough to ask, what is the problem we're trying to solve? Is AI appropriate? Is there a simpler option? Right down to questions like, are we solving the right problem? It should be a practical safeguard against AI for the sake of AI. And thirdly, it should support clinical safety thinking, and again, in a proportionate way. It's not about adding paperwork. It's recognizing absolutely the nuance and some of the difficulties in this space. But fundamentally, it's about recognizing the importance of preventing harm. And some tools, some that we've talked about today, like those used in diagnostics or clinical assessment, might qualify as medical devices. Others sit in lower risk spaces. So they should give teams the language and structure to say, here's the risk, here's the intended use, here's the level of oversight we might need to make, and ultimately protecting staff, patients, and helping organizations make better decisions. And I'm conscious of time, so I'm just going to fly through these last few. Information governance and data protection, really important. What the framework does is support some of the thinking around this, particularly the basics around why is data being used, what data is being used, why, where does it go, who can see it, how can protect it, how is it protected, those sort of fundamental questions. Evaluation and monitoring. This one's around AI not being sort of fire and forget. They need to be understood, they need to be tested, they need to be monitored over time. You know, a tool could perform really well in the first few weeks, but that could change it whenever you move to scale, and what happens with different patient groups, or what happens when workflows change, or when staff get used to the system. So the framework encourages teams to consider things like baselines and feedback loops and simple measures of success. And importantly, that evaluation is not about stopping innovation. It's actually about making sure the things that work can be scaled. And then finally, encouraging teams to work not in isolation. One of the biggest risks could be about everyone sort of experimenting separately and duplicating effort and solving the same problem multiple times, or repeating avoidable mistakes. So I think that the framework connects the teams back into the wider system through things like the HSC AI steering group, the subgroups of that particular group, and the communities of practice that we're building out, emerging pilot work, and guidance from clinical safety, IG, technical colleagues, and just sharing some of that good stuff that's happening across the region. So look, I'll close with that. I think what we will do is recognize the framework is here to help. It's not a rule book, it's not bureaucracy, and it's definitely not the final word, and it doesn't have all of the answers, but it probably helps you with asking some of the right questions, and a shared scaffolding to make progress a bit easier, and give us a common starting point. And we'll continue to build on it through the HSC AI steering group, and other forums as appropriate. It's a living document. It'll continue to grow as our experience grows. So look, I just want to thank all of you for joining us, but particularly to our speakers, Dr. Sterling and Eddie. I'll end with this. AI is not something that happens to the system. It's something that we collectively have a shared responsibility for shaping together, and your ideas and your concerns and your experience are vital as we move forward together. So please explore that framework, use it in your teams, let us know what works, let us know what needs to develop, and yeah, let's keep the conversation going. So thank you all for joining us. That just about takes us to time, but I'm going to just come to Dawn quickly. I can see people are dropping out as they jump on to the next meetings on Friday afternoon. And Dawn, did we have questions?
Yes, there were a couple of questions, but between Patty and Eddie, they have answered them, I believe, as we went along. They've put answers in the chat. As Eddie has put there, the chat will remain open after the meeting. So if anyone has any further questions or needs clarification, by all means, put them in the chat or drop me an email, and we can get you answers or pick up on it.
Wonderful. Okay. Thank you very much, Dawn. Thank you, folks. Nice to see you all. Take care and see you soon.
Thanks very much, everyone. Thank you.
Bye.
Bye.